This content is for educational purposes only and does not constitute legal or medical advice. Laws and clinical guidelines vary by jurisdiction. Case details are drawn from publicly available court records and legal reporting. A 33-year-old woman presents to an emergency department in the southeastern United States with acute lower back pain radiating into her hip and leg. She is uninsured. She has no primary care physician. She weighs over 400 pounds. Over the next 2 weeks, she will return to that emergency department 4 times. Her symptoms will escalate from back pain to numbness in her legs, buttocks, and perineal area. She will develop incontinence. Each time, she will be diagnosed with sciatica, given pain medication, and sent home. On her final visit, the emergency physician orders an MRI, but not an emergent one, an outpatient one, to be scheduled through a system the patient has no insurance to access and no primary care physician to coordinate. 1 week later, she presents to a different hospital. The diagnosis is immediate. Cauda equina syndrome from a massive disc herniation at L5 to S1. She is transferred emergently for surgical decompression. But the compression has persisted for weeks. The therapeutic window has closed. She is now permanently incontinent, largely confined to a wheelchair, dependent on chronic catheterization, and suffers recurrent episodes of sepsis requiring frequent hospitalization. The jury returns a $5.2 million verdict. And then the state's comparative negligence statute reduces it, because the patient did not get the MRI she was told to get, but had no realistic way to obtain. This is the charted defense. I am Bryan.
I am Sarah.
And I am Michael Coleman. Today we are looking at a case that illustrates one of the most dangerous patterns in emergency medicine malpractice, the outpatient MRI order for a condition that requires emergent imaging. The physician identified the right test. He ordered it through the wrong pathway, and that distinction cost over $3 million and a patient's independence.
The patient's first visit to the emergency department occurs in the summer of 2011. She presents with acute, severe lower back pain. The emergency physician evaluates her, prescribes pain medication, and discharges her home. Over the following 2 weeks, she returns 3 more times. Her symptoms escalate. By the second week, the medical record documents sharp pain radiating bilaterally down her legs, numbness in her buttocks and vaginal area, and new-onset incontinence. Emergency medical technicians responding to a 911 call document abnormal sensations in her lower extremities bilaterally, and vaginal numbness that has been present for 5 continuous hours. On the visit that becomes the focus of the litigation, the emergency physician evaluates her and documents a diagnosis of exacerbation of sciatica. He prescribes pain medication, provides discharge instructions to follow up with a family physician, and orders an outpatient MRI. Michael, what are you seeing in this clinical timeline?
Looking at this timeline, a few things stand out. You have back pain that starts unilateral and progresses to bilateral symptoms across multiple visits. You have new onset numbness in the saddle distribution, the perineum, the buttocks, the vaginal area, and you have incontinence. Those findings, taken together, move this beyond a straightforward sciatica presentation. Those are the red flags for Cauda equina syndrome, and every emergency physician learns the list. Now, I want to be fair. CES is rare. It accounts for roughly 0.3% of back pain presentations. An emergency physician or a hospitalist may encounter one genuine case across an entire career, and the individual red flag symptoms perform poorly as screening tools. Pooled sensitivity for saddle anesthesia is about 35%, urinary retention about 30%, bilateral leg pain about 43%. No single finding reaches 50% sensitivity. But this patient was not presenting with a single isolated red flag. She was presenting with multiple red flags that were escalating across serial visits. That changes the calculus entirely. When you have progressive neurological symptoms across multiple encounters, especially new onset saddle numbness and incontinence in a patient with severe back pain, the standard of care is emergent MRI, not outpatient referral. And I think it is worth being honest about something we all deal with in the emergency department. Back pain is one of the most common chief complaints on any shift. A significant number of those patients are presenting with outpatient issues, and some are presenting for secondary gain. That reality creates a cognitive environment where it becomes easy, not excusable, but understandable, to miss the one patient who genuinely has a surgical emergency buried in the noise. That is not a defense, it is a reminder to be deliberate about the red flag screen every time, especially on the second or third visit. And consider this: if a plaintiff's attorney can point to your chart and show documentation of drug-seeking behavior or chronic pain language where you have placed objective findings that suggest this is not an emergency, they can paint a picture of a physician who made an assumption rather than a diagnosis. That framing is extraordinarily difficult to defend against. Your documentation should reflect what you evaluated and what you ruled out, not the narrative you formed about why the patient was there.
Sarah, the physician, ordered an MRI. Why is the distinction between outpatient and emergent imaging legally significant?
Because ordering the right test through the wrong pathway can itself constitute a breach of the standard of care. The physician identified that imaging was needed. That was correct. But the standard of care for suspected Cauda equina syndrome, as established in the medical literature and professional guidelines, requires emergent MRI. The GIRFT national pathway. Getting it right. First time specifies that imaging should occur within 1 to 4 hours of the clinical request. An outpatient MRI for a condition that requires decompression within 24 to 48 hours to preserve neurological function is not a slower version of the same order. It is a fundamentally different clinical pathway, one that discharges the patient into a fragmented scheduling system where the median time to obtain a scan can stretch to days or weeks.
And here is where the systemic reality compounds the clinical failure. This patient was uninsured. She had no primary care physician. She weighed over 400 pounds, which means the outpatient imaging facility would need an open MRI or a unit rated for her body habitus. Navigating that referral pathway requires insurance authorization, scheduling coordination, and often upfront payment. For this patient, the outpatient MRI order was functionally impossible to execute. The plaintiff's attorneys made this argument explicitly at trial, that the clinical team should have recognized that discharging an uninsured, morbidly obese patient with instructions to independently secure complex outpatient imaging was not a viable clinical plan. The emergency department had the resources to image her that day. The physician chose not to use them. I understand the pressures of emergency department throughput. I understand that back pain is one of the most common complaints you will see on any shift, and most of those patients do not have Cauda equina syndrome. But when red flags are present, and especially when they are escalating, the imaging needs to happen before the patient leaves your department. The literature is clear on this. Patients with suspected spinal cord compression should not be discharged without definitive imaging.
1 week after the final emergency department visit, the patient presents to a different hospital. She is now complaining of profound decreased sensation, severe pain, active incontinence, and constipation. The medical team at this facility immediately recognizes the severity. They diagnose Cauda equina syndrome secondary to an acute disc herniation at L5 to S1. She is emergently transferred to a university hospital, where a neurosurgeon performs surgical decompression, removing what was described at trial as a large ruptured disc. But the mechanical compression has persisted for weeks. The nerve damage has progressed from neuropraxia, a temporary physiological block, to irreversible structural disruption. The surgical window for optimal recovery has closed.
The permanent injuries in this case are severe. Loss of bladder function requiring chronic catheterization, bowel incontinence, difficulty walking, and she is largely wheelchair-bound, radiating back and leg pain, numbness in her feet, and recurrent episodes of sepsis related to the catheter requiring frequent hospitalization. During the trial itself, she was hospitalized for sepsis. This is the clinical reality of delayed CES diagnosis. CES is one of the few conditions in medicine where the difference between a timely diagnosis and a late one is not incremental, it is categorical. A patient decompressed within 24 to 48 hours of symptom onset has a reasonable chance of meaningful neurological recovery. Beyond that window, the damage becomes permanent. Time is spine.
The malpractice action is filed in a state court in the southeastern United States. The jurisdiction is significant because this state has a specific legal framework for emergency medicine malpractice that physicians need to understand.
This state provides emergency physicians with a heightened liability shield. Under the applicable statute, a plaintiff suing an emergency physician for care rendered in a hospital emergency department cannot succeed by proving standard negligence. They must prove gross negligence by clear and convincing evidence. Gross negligence under this framework means the absence of even slight diligence, a complete failure to exercise the care that every person of common sense would apply to their own affairs. That is a significantly higher bar than ordinary negligence. In a typical malpractice case, the plaintiff only needs to show, by a preponderance of the evidence, that the physician deviated from the standard of care. Under the state's emergency care statute, the plaintiff must clear both a higher evidentiary standard, clear and convincing, and a higher conduct threshold, gross negligence, rather than ordinary negligence. But it is worth emphasizing that a higher bar is not an impenetrable one. When the pattern of omissions is sufficiently striking, juries have shown a willingness to find gross negligence even when the statutory standard was designed to protect emergency physicians. Despite that protection, the plaintiff's legal team argued that the cascade of failures met the gross negligence threshold. They alleged that the physician failed to review the patient's prior visit records, failed to obtain an appropriate clinical history, failed to perform a comprehensive physical examination, targeting the documented areas of decreased sensation, failed to determine if the patient was physically capable of walking, and, most critically, failed to order emergent imaging when the patient was in the facility with the resources available.
From an analytical standpoint, the jury's response here is worth examining carefully. Gross negligence is not limited to affirmative, reckless acts. It can also encompass a pattern of omissions, a failure to perform the basic clinical steps your training requires when the presentation warrants them. 4 visits, escalating red flags, saddle numbness, incontinence. And the clinical response was discharge with an outpatient MRI order the patient had no realistic means to fill. A jury looking at that sequence is evaluating the totality of the clinical response, not any single decision in isolation.
The defense argued comparative negligence, that the patient bore responsibility for failing to obtain the outpatient MRI she was instructed to get.
This state operates under a modified comparative negligence system. Under the applicable statute, a plaintiff can recover as long as their own fault is below 50%. If the jury finds the plaintiff 50% or more at fault, recovery is completely barred. Below 50%, damages are reduced proportionally by the plaintiff's share of fault. This is different from the pure contributory negligence rule that still exists in a handful of jurisdictions. In those states, any patient fault that proximately contributed to the injury can completely bar recovery. In this jurisdiction, it is a sliding scale. The patient can be found partially at fault and still recover, just at a reduced amount.
The jury deliberated for approximately 10 hours. They returned a $5.2 million gross verdict. And they assigned 40% comparative fault to the patient for failing to obtain the MRI. Sarah, walk us through the math.
The gross verdict of $5.2 million is reduced by the patient's 40% share of fault. 40% of $5.2 million is $2.08 million. That amount is subtracted, leaving a net recoverable award of $3.12 million. It is worth noting that the entire verdict represented medical costs and non-economic damages. No lost income claim was included. And the state's non-economic damages cap had been struck down as unconstitutional by the state Supreme Court the year before these events, so no cap applied.
The 40% comparative fault finding deserves attention. Post-verdict conversations with jurors revealed that 3 jurors had been firmly pro-defense, but the group reached a compromise through the comparative negligence allocation. The jury was saying 2 things simultaneously. The physician's failure to order emergent imaging was gross negligence, and the patient bore some responsibility for not pursuing the outpatient study. But 40% fault still left a $3.12 million judgment. For physicians, the lesson is important. Patient noncompliance may reduce your liability under comparative negligence, but it does not eliminate it. And when the noncompliance involves an instruction the patient had no realistic means to follow, the jury may discount that defense significantly. The 40% here may have been generous to the defense.
The settlement history in this case is instructive. Before trial, the defense offered $150,000, later raised to $350,000. During trial, the offer rose to $750,000. During jury deliberations, the defense offered $1 million. The plaintiff countered at $2 million, the physician's insurance policy limit, and then offered to settle at $1.5 million. Both were declined. After the jury sent a note suggesting difficulty reaching a verdict, the defense pulled the $1 million offer and texted a $500,000 offer. Before the verdict was returned, both parties agreed there would be no appeal.
I bring this up because the settlement trajectory illustrates something physicians need to understand about the litigation process. A case that was valued at $150,000 before trial was valued at $5.2 million by the jury. The defense had multiple opportunities to resolve this for a fraction of the verdict, and each time they bet on the gross negligence standard protecting them. It did not.
Michael, bring it home.
3 things. First, if a patient presents with any combination of CES red flags, saddle numbness, new onset incontinence, bilateral leg symptoms, progressive weakness, order emergent imaging before they leave your department, not outpatient, not ASAP, emergent, and personally confirm with radiology that the order is being treated as emergent. An outpatient MRI order for suspected spinal cord compression is indefensible in litigation and dangerous for the patient. The literature and the guidelines are unambiguous on this. Second, document the absence of red flags specifically. When you evaluate a patient with back pain and determine that CES is not present, your chart should reflect what you looked for, not just what you found. Document intact saddle sensation. Document the absence of urinary retention or incontinence. Document normal rectal tone if you performed that exam. Neurointact is not sufficient. A targeted, specific negative exam protects you. A vague, templated one does not. Third, before you discharge a patient with complex follow-up instructions, verify that the patient has the ability to actually follow them. Can they obtain the imaging you are ordering? Do they have any financial barriers to obtain the imaging? Do they have a primary care physician to coordinate the referral? Do they have transportation to the facility? If any of those answers is no, the discharge plan is not executable. And a plan the patient cannot follow is not a plan. It is a gap in the care. When those barriers exist, involve case management and social work early. Help establish a feasible pathway, whether that means imaging in your facility before discharge, arranging direct transfer, or connecting the patient with resources that make the follow-up realistic. Do not offload a potential surgical emergency onto an outpatient system that was never designed to handle it.
The right test, ordered through the wrong pathway. A physician who recognized the need for imaging but discharged a patient into a system she could not access. A $5.2 million verdict reduced by 40% for a patient's failure to do something she was never realistically able to do. Michael, the bottom line.
If the red flags are present, the imaging happens before the patient leaves your department. There is no outpatient pathway for a surgical emergency. And I want to leave you with this thought, because it is a pattern we keep seeing. Ordering the right test actually shows that you are thinking along the right clinical path. The physician here considered the possibility that something beyond sciatica was happening. That is good clinical reasoning. But ordering it through a delayed outpatient pathway undermined that reasoning entirely. The order itself becomes evidence that you recognize the concern and then chose a response that did not match the urgency of what you were considering. We saw a similar pattern in our Season 3 coverage of On the Record, where the clinical team identified the possibility of fungal pneumonia and started antifungal therapy, but chose an oral azole appropriate for mild disease when the patient's severity demanded intravenous amphotericin. In that case, the order demonstrated awareness of the diagnosis, but a mismatch between the treatment intensity and the clinical picture. The principle is the same. Every order you sign should reflect not just the right diagnosis, but the right urgency and intensity for the patient in front of you. An order that acknowledges the problem but responds to it inadequately can be more damaging at trial than no order at all, because it removes the argument that the diagnosis was never considered.
Thanks for joining us today on the Charted Defense. We will see you next time. This content is for educational purposes only and does not constitute legal or medical advice. Laws and clinical guidelines vary by jurisdiction. Case details are drawn from publicly available court records and legal reporting.